of course, series. She is the president of IMS and the governing council member of ICOG. Ma'am is being the secretary general of IMS as well. I welcome you, ma'am. Now I hand over the mic to Dr. Simi, who would go ahead and introduce the panelists so that we can start the session.
Wait for a minute. Let me welcome everyone.
Yes, ma'am.
So, welcome, dear colleagues and my friends, to this 21st episode of our CCC webinar series. I am honored to introduce this session moderated by a distinguished Dr. Udit Thanewala, Chairperson ICOG 2021, Vice President of Oxy 2015. Dr. Thanewala will be addressing the critical issue of intrauterine infections. What next? Intrauterine infections during pregnancy present some of the most complex, challenging issues in the field of obstetrics, and these infections require a comprehensive, multimodal approach that encompasses medical interventions, patients' education, ongoing research. Despite the tremendous advancements in medical science, the complexity of these infections often reveals that the depth of what we still need to learn. Effective treatments, patient counseling, and demand that we continuously update our knowledge and techniques to ensure best practices. Our panel of today include esteemed experts in the field, Dr. Amruta Gomthekar, Dr. Kuntal Jadeja, Dr. Madhu Chandra, Dr. Itambara Bhalla, Dr. Rajuta Fuke, Dr. Santosh B, Dr. Sujata Velanki, Dr. Vasundhala. I would also like to acknowledge our dedicated coordinators who have worked tirelessly to organize this webinar, Dr. Sini Gopal, Dr. Manisha, and Dr. Suti. All of them have been working day and night to coordinate the whole session. So I would like to give the session back to Dr. Manisha again. Sini? Okay. Sini?
Hello.
Hello, Dr. Sini.
Yeah.
You can take it.
Yeah. So today, excuse me. So it's a great privilege to be here and welcome you all for today's panel discussion. And today we have a very important, a very interesting panel discussion on intrauterine infection. What next? So for this, we have a wonderful moderator for this today's session. Welcome, Dr. Uday Thanewala, sir. He was a VP Foxy 2015 and Chairperson ICOG 2021. I welcome you, Dr. Uday Thanewala, for this wonderful moderation or for this wonderful panel discussion. And we also have a very great, learned, very respected and very well informed. We have wonderful panelists for today. I would like to welcome Dr. Amruta Gomthekar. I think she has not joined right now, but she's the secretary of the Solapur Obs-Gynec Society. And next, I would like to welcome Dr. Kuntal Jadeja. Sir, he is the president of Rajkot ONG Society and also she's a fetal medicine consultant. And next, I would like to welcome Dr. Madhu Chandra, President of Warangal Obs-Gyn Society, and the main areas of interest, PCOS and high-risk pregnancy. And next, I would like to welcome Dr. Ritambara Bhalla. She's the secretary of Chandigarh ONG's Obs-Gynec Society. And the main areas of interest for her are the high-risk pregnancy and postmenopausal health. She is also the executive member of the IMS Chandigarh chapter with lots of years of experience. Next, I would like to welcome Dr. Rujita Fuke, secretary of Nagpur ONG Society. Next, I would like to welcome Dr. Santosh Jaybhai. He's the VP of Navi Mumbai and the Joint Director of Om Sai's Multispeciality Hospital. And apart from that, he has so many other, skills, which is very which we don't see a lot in doctors. Like he's a marathon runner, a trekker, a finance teacher, and whatnot. And he's also a very good friend of mine. Welcome, Dr. Santosh. Now I would like to welcome Dr. Sujata Velanki. She's the secretary of the Vijayawada ONG Society, with lots of publications and awards and accolades to her credit. She's also the clinical head and fertility specialist at Oasis Fertility Vijayawada. Next, I would like to welcome Dr. Tabassum Dalla. She is the president of Raipur ONG Society and also the senior consultant, Cloud9 Hospital. And she's also the recipient of numerous awards. So now I request Dr. Uday Thanawala sir to take over and let us all have this great panel discussion where we'll be getting a lot to learn and take home good take home messages.
Sorry, you are on mute.
So your slides are seen only. You need to go on slideshow mode. Yes. Okay, sir. Sir, you're muted, sir.
बढ़िया है dear
Sorry, you are muted.
डॉक्टर, आपका नेम क्या था? शिफाली? नहीं.
Okay,
Yes, sir.
sorry, there was some confusion here.
Yes, sir.
You want on the slideshow, right?
Yeah, yeah, sir, yes.
Okay, so here we are. So when we were talking about intrauterine infections, it is such a wide topic, that what do you do? Like you have questions about chickenpox in pregnancy, you have questions about COVID in pregnancy, you have questions about any viral infection or bacterial infection in pregnancy. So ultimately, I said, no, there is a lot of confusion happening in the area of torch because I see so many reports of torch coming, and the important thing is how to navigate when you get a positive report and in which cases do you do a torch titer. So I said, let me start with torch titers only, and let me start with this, and I have handled one or two cases which I'll bring to your, we will discuss over here. And if time permits, we will take as many infections as we can. But first, let's focus on the torch infections. And these are all our panelists. I think some of them are not there. I have just put the questions according to the order which I was given in. So it's not directed at anybody whoever is next can answer the question. So I think Amruta is not there, right? Is Dr. Amruta there? Has she joined? No. So let me ask. There's somebody who is not named. Okay, Dr. Ritambara Bhalla can go ahead. And what does TORCH stand for? And if you could tell us briefly, what are the organisms responsible and the disease which they produce?
So, hi, good afternoon to everyone. I'm Dr. Ritambara Bhalla from Chandigarh, and thank you for including me in this fabulous panel. Coming to the TORCH infection, TORCH, as we all know, is acronym for T stands for Toxoplasma, O stands for other infections, which includes HIV, syphilis, parvovirus, varicella, and Zika now. Rubella is for R, C is for cytomegalo and virus, and H is for herpes simplex virus infection. So toxoplasmosis, sir, should I continue?
Yeah, please. I want you to tell all this.
So toxoplasmosis is caused by Toxoplasma gondii. It's a ubiquitous parasite found in mammals. It is generally found acquired when you are taking undercooked meat, and especially if you are exposed to cats. So we always tell our patients, and in fact ask them upfront, do you have pets as cats? So if the women have cats as their pets, toxoplasmosis can occur to them, and so that should be kept in mind, especially when you find a microcephaly or a hydrocephalus or an intracranial calcification on the ultrasound. So next is rubella. Rubella is also known as German measles, and it presents like a URI kind of a symptom, but URI with a rash. The causative virus is the rubella virus it's a toga virus family group, and it causes lots of havoc in the baby if it is acquired during pregnancy. So ideally, you must get all your females vaccinated prior to they conceive, and if not, check their vaccination status if they come and meet you preconceptionally. So baby gets lots of cardiac malformations, hepatosplenomegaly, and microphthalmia. And in postnatally, when the baby gets born and you are not knowing that the baby is suffering from rubella, there will be sensory neural deafness, cataract, meningoencephalitis, and they can also have mental retardation if not diagnosed in time. Next, coming to CMV or cytomegalo, it's a herpes simplex virus family group, and it presents with low-grade myalgia, fever, and most often it is missed in antenatal period. We pick up these ladies and when they present with intrauterine retardation, and there is a classical cerebral ventricular megali. If detected late, we would have fetal hydrops, chorioretinitis, and intracranial calcification. Most often, when the babies are born undiagnosed, we end up with a congenital CMV infection, have long-term effects, which is essentially hearing loss, classically jaundice, and these babies are to be treated postnatally. Herpes simplex virus is of two types, type 1 and type 2, and it is the
You are muted, Rita. Sir. Yeah, better now.
and ultrasound shows IUGR, and that's where you pick up this infection. And there is local lesion in herpes, which we pick up during our antenatal checkup. And the babies get microcephaly, hydrocephalus, and we will have IUGR, as I said.
Great. Fantastic. Dr. Bhalla, you have covered it very well. Now, Dr. Kuntal is not there, right?
Yes, I'm here, sir.
Oh,
Unlabeled
good.
person.
Yeah, please label yourself. So, do you ask all your patients to get a torch titer done, or do you do it in recurrent abortion cases, or which cases would you want a torch titer?
No, not in all low-risk patients. We should not ask them, and not also in the recurrent miscarriage cases, as it cannot be a cause of recurrent miscarriage. Infection can never be a cause of recurrent miscarriage. So both.
Excellent. So this was a catch question. So you've answered it very well. That it's not a cause of recurrent infections. And according to the FOXY, GCPR is not recommended for low-risk cases, and it should not be done because it's not a cause of recurrent miscarriage. If a torch infection occurs in the first trimester in pregnancy or in the second trimester, and you lose the pregnancy or lose the baby, it's not going to happen again in the other baby. So it's not a cause of recurrent miscarriage. So in which cases will you ask for this? Dr. Madhu Chandar is there? Or Dr. Kuntal, you can continue.
Mostly when in ultrasound, we find ventriculomegaly or some findings like IUGR or oligohydramnios. And also if there is a hydrops, CNS finding, calcification in hepato or spleno, or in this
so any
finding leads us if there is any indication of.
So ultrasound is the main thing, because remember this, that it is any of these infections, a woman can have mild fever, a little bit of rash, which you may not even notice, patient may not even notice, but it is ultimately the ultrasound findings which will make you realize that there's something not right in this pregnancy. And I'll come to the case which I want to discuss. But tell me something, if there is a pregnancy loss in the first or second trimester with no other obvious cause, would you do a torch titer just to know what is happening?
Yes.
No.
Yeah, so now there's one yes and one no. So I want to know what is. Ritambara said no. So Ritambara, why not?
Sir, because unless if there is a loss in the first or the second trimester, it doesn't necessarily be torch is generally not responsible unless there is a associated IUGR or something like that. Torch is we used to do when I was studying, but no longer done nowadays. So we believe that torch is. And secondly, it is not going to have any implication in the second pregnancy.
Yeah.
So second trimester losses are generally implicated to cervical incompetence, or sometimes related to some genetic defect in the baby, which would be more on cards rather than a torch infection.
Yeah, but suppose the baby had IUGR or the baby had a problem, so we don't know. So you are right in saying don't do a routine torch titer for first or second trimester investigation, because it doesn't help you with the prognosis of the next pregnancy or doesn't help you there. But for this particular pregnancy, if nothing else is wrong and the patient wants to know that, okay, fine, one can possibly do a torch and see whether anything was wrong, because it is more to satisfy a patient that everything is okay.
Complete the investigation.
Sir, there we come to the fact that how do you interpret a torch if it comes as positive? We need to do a repeat torch to see the titer subsequently, to see whether there is a rising or a falling titer. IgG positive will never help you. So IgM alone itself, standalone, does not have too much bearing.
Okay, yeah. So I'm going to come back to you, Rita, for that. And there's somebody raising a hand, but I'm not going to allow anybody else except the panelists to speak right now. So please keep your questions in the chat box and we will see if we can answer them if the time allows. So a 28-year-old primigavida asthmatic on treatment came for an anomaly scan at 19 weeks. And can you see your screen? What this is? This is the fetal head. This is the amount of liquor there. And basically what I found on this particular scan is that there was a thick placenta and the liquor was low. Okay, now medically she was on nebulization, anti-scan was normal, ANC profile was normal, double marker was done at 12 weeks, which was low risk, flu vaccination was given, and we sent her for a repeat the ultrasound findings, they remained the same. So there was a thick placenta and a little less liquor at 19 weeks of gestation. So would you ask for a torch titer in this case?
Yes, I would, sir. In this, because as you said, there's a placentomegaly. So placentomegaly tells us that there is a likelihood of some kind of a fetal-maternal infection. And these are the candidates where if the placenta was small, shrunken, I would maybe label it as a placental cause. If I have a PAPE, I would look at PAPE and label it as a primary cause, not as a placenta. But placentomegaly, less liquor initially, and IUGR, that cards are tilted towards torch infection more than anything else.
So placenta-megaly will also occur in a high blood sugar patient, right?
Yes, sir, but not so soon, not at 19 weeks.
Great. So how do you interpret your task? Go ahead and tell me your interpretation.
So, sir, if when we have, as we all know, IgG is responsible for an old infection, and IgM tells us about the recent infection in last 3 months. So both IgG and IgM are if negative, that means the patient is not immune and not vaccinated and is not infected at the moment, right? And if you have IgG negative and IgM positive, means that the patient is now has acquired infection in last 3 months, an acute infection. And if the patient is IgM negative and IgG positive, then it means that there has been a past infection or an immunization, which tells us that the patient is immune to that particular infection.
So IgM levels are more important and not IgG. So we had sent this torch titer. We got a toxo IgM positive at 4.2. and IgG at 108. We also got IgG, IgM negative for the HSV. We got rubella, IgG positive, and we got CMV, IgG very high positive. So does the patient have all three?
No. As I said, IgG means an old infection. IgM positive was only in toxoplasmosis with the placenta thick, and IUGR, I would possibly consider toxoplasmosis as a primary cause for intrauterine infection and not
So
any other
basically, yeah.
infection.
So basically, a negative IgM antibody test virtually rules out a recently acquired infection. And women who are positive for IgG and negative for IgM are defined as immune, and no further follow-up is necessary because the fetuses are not at risk. And of course, rubella every time should be positive. I get so many patients who come to me with rubella positive, and they've been started on various sorts of medicines for the toxoplasmosis, which I don't want to say just now. But the patient is asking you, Santosh, that how the hell did I get infected? You are telling her, look, there's a chance the blood tests say that there's toxoplasmosis in your which you have acquired, and the patient wants you to explain how have I got this toxoplasmosis and what the hell is toxoplasmosis? What will you tell her?
The close contacts with the pets, especially the cats, contact with the contaminated soil, eating of uncooked meat, especially lamb and beef. These are the commonest reasons by which act as a source of infection and reason for entry of the toxoplasma into body of the patient.
Patient says, "मेरे घर में तो बिल्ली नहीं है, मैं तो बिल्ली के पास भी नहीं जाती." So many a times it is not even possible to find out that how she's got infected. So now, how do you diagnose that this infection is acute, Santosh?
So we'll go for the toxoplasma titers, especially the IgM titer. Generally, that IgM titers are positive within first 2 weeks of infection, and they remain elevated for quite a longer period of time. So mere positive IgM titer may not give us an idea whether patient has been infected few days before or maybe few months before. So in such situations, if you repeat the titers and there are rising IgM titers, then we can say that this is a infection that has been there in recent past. Coupled with negative IgG, that means that again it's an indicator that the infection is a recent infection.
Great. So basically, to clarify everything, IgM has to be positive, or your IgG has to rise to a 4-fold level in the subsequent test which you do to confirm that there is a toxoplasmosis infection. But now you've got this patient who is 19 weeks, who's showing you some signs that there's something wrong, and that is the reason where you've asked for a torch titer. That's the reason when you've got toxoplasma positive. What is the next step which we should be doing, Dr. Sujata?
Yeah, actually, once the results are positive, we are looking at what are the chances of the fetus getting infected. So look at
so one very important point is that the moment you get a woman confirmed to be positive in a particular infection, do not assume that the fetus will be always infected, right?
Yes. So depending on her period of gestation, the transmission rates vary. So the chances of transmission are on an average about 30%, but the transmission rates are very high as the period of gestation keeps on increasing. That is, as she moves nearer to the term, the chances of infection of the baby is high. But the paradigm here is like, though the infection rate is higher as we advance in the period of gestation, the chances of baby getting congenital infection tends to become lower. So there is but one point, it is in the mid-trimester, where we look at, suppose, say around 20-25 weeks. That is the time when the chances of the baby getting infected are the highest. So we need to assess like what is the period of gestation that she is in, and what is the risk that the baby might get the infection.
So you're very right. Women who seroconverted 24 to 30 weeks of gestation carry the highest 10% risk of severely congenital infected infant. And although the frequency of infection is higher later in pregnancy, the third trimester congenital infection appear to be mild and rarely result in a severe affected infant. Now, this is important to realize because once you diagnose a woman to be positive, it's not always that the fetus will be infected, and one has to analyze that what is happening to the fetus and what should we do. So how do you know the timing of infection, Dr. Tabassum?
Good evening, everyone. The timing of infection can be known by doing a test called avidity test. And once you find a very high avidity test, that means that the infection has happened before. That means less than 3 months before. And if the avidity is low, that means the patient would have got infected within 3 months of the test. So that is how we can.
So our patient is say 19 weeks. So if
she would
her
have got
avidity
infected
is
around
low,
11, 12 weeks.
yeah. So we repeated the toxo titers anyway to confirm what is happening, and the avidity was low. And now you are suspecting that this patient has got infected in pregnancy. What do you do next?
Then we have to find out if the baby is already infected.
Yeah.
So to find out baby's infection, we can find it only by doing invasive testing like amniocentesis.
Okay, great. So we want to now know whether this infection has gone to the baby or no. So to establish a fetal infection, the detection of antibodies, we have to do an amniocentesis and send the amniotic fluid for a toxo-PCR.
Yes.
What do you think? Is it going to be easy in this case to do a amniocentesis?
Because we are finding one thick placenta, so we may have difficulty in doing amniocentesis. But
And the liquor is less.
So expert in amniocentesis would be able to perform the test.
So tell me something, how will it help you to know if the fetus is infected or not? How does it make a difference in your management?
So if the fetus is if the fetus is already got infected, then we can start the patient on the medicines.
And if the fetus is not infected?
In any case, we have to start her on medicines.
So then how does it help?
If the fetus is infected, then we may offer her termination if the anomalies are severe.
Okay, how many of the panelists will agree that they will terminate? All of you, all of the panelists who are there.
Must prognosticate and and termination, of course, I have never done in my life, but then yes, prognostication is what we must always do. If there is a definite sensory neural involvement, we may have to think of termination.
Santosh, what is your view?
Sir, at patient is at around 20 weeks and some sort of growth retardation and oligohydramnios is already set in. So I may not directly offer the termination to the patient, but I will explain the guarded prognosis to the patient and relatives, and we'll wait for their.
No. You're not getting the point. Here the question is if the fetus is infected or not infected. By doing amniocentesis and you're finding out whether the fetus is infected or not infected, how it is going to help you.
We can, if we find out, we can treat that infection. This infection is treatable. So
exactly. Now, who's that? I can't see over
Dr.
here.
Tabassum. Dr. Tabassum.
Yeah, so Tabassum, the important thing here is you must understand that the treatment is different for both the things. If your fetus is infected, the treatment is directed towards toxoplasmosis to kill the agent. If your fetus is not infected, then we have to just prevent and give her another drug to prevent the transmission. That the mother is infected, mother needs to be treated, but fetus need not be treated, and she should not transmit the toxoplasmosis to the fetus. So that is the importance that we need to know whether the fetus is infected or not. Because even if you find out if the fetus is infected, this infection is treatable. We will not think of doing a termination, And over here, if it is positive, we treat the fetus. If it is negative, we counsel the patient that abhi tak bachche ko kuch infection nahi hua hai. But we need to start medication so the infection doesn't pass on to the baby. And right now, for this, on the basis of a positive amnio also, there is no indication for medical termination because it is treatable. Timing of amniocentesis, I think everybody knows that we should not wait before 18 weeks or less than 4 weeks after the estimated date of maternal infection, because we want it after 4 weeks of maternal infection. Here, she is 19 weeks and she's come positive. So we can probably do it now. So we waited here in this case because the LICA was a little less. We wanted the baby to grow a LICA to improve a little bit. And we did it a week later after we discovered this. And the sensitivity and specificity is very good. At 20 weeks, the patient was subjected to an amniocentesis. And this is the amniocentesis report. So the specimen is negative for the full torch panel. And all other parameters were normal. Even chromosomally, the baby was normal. And the microarray was also normal in this case. So what is the treatment for toxoplasmosis, Kuntal? If the toxo-PCR, suppose it had come positive, suppose the baby was infected, then first you tell me what is the treatment which you will give to the patient, because that is technically the treatment for toxoplasmosis.
When
Dr. Kuntal? Yeah.
Yes, sir. So first, before when amniocentesis, we have if we are suspecting toxoplasma upward IgG-M positive, then we should start spiramycin. And if amniocentesis suggests fetal infection has already been setting, then we should switch over to pyrimethamine and sulfadiazole combination. And
excellent.
Pyramycin should be as such stopped after 1 week. If fetal infection is...
We'll come to pyramycin. First, let's make it very clear to all the audience that if the fetus is infected, this is what you give. You give pyrimethamine 1 tablet of 50 milligrams daily. You give sulfadiazine 3 tablets of 500 milligrams twice daily, and folinic acid 2 capsules of 25 milligrams per week. You agree with this?
Yes, sir.
Okay, is the correct dose what we are giving?
Yes,
everybody? Everybody agrees with this?
Yes,
Yes.
And sulfamycin, this is the dose which you should give to the patient to treat if the fetus is infected with toxoplasmosis, and we hope that the baby would do okay. And if your amnio-PCR is negative, you can go on, Dr. Kuntal, and the fetus is not affected. What do you give is pyramycin, and what is the dose which you said?
We should be give until delivery. It should be continued, and 1.5 milligram BD.
Okay, so 1.5 milligrams of pyramycin from diagnosis until delivery you will give. And this is what toxoplasmosis is about. Because it's a treatable disorder, we must know how to navigate all the steps and how to come to a conclusion on what treatment to be given. So since our patient's amniotic fluid PCR was negative, we started her only on pyramycin, and we continued it till delivery.
Even if amniocentesis is negative, fetus might be infected or may get infected. So you have to continue pyramycin even if it comes negative till delivery.
That is what I was also going to say, sir. Because in those days when we were residents and we could not do amnio, we were not that good, and the machines of ultrasound were not that good. We used to start pyramycin at the first suspicion, and I have never seen any baby who had congenital toxoplasmosis. I studied in Mahatma Gandhi Institute, which is in Nagpur, near Nagpur, where we used to have lots of cattle and animal infected babies. And therefore, we had at least twice in a year, we used to give pyramycin to patients, and none of the baby ever had any congenital affection.
Yeah. So the important thing is that if your amniocentesis is negative, that means the baby is not affected. In that case, infected, then you can start pyramycin, and you have to start pyramycin and continue it. But if there is fetal toxoplasmosis, which is proved by your amniocentesis being positive, then it is to give her pyrimethamine and sulfadiazine. Now, in this case, till the amnio result came, from that 19 to 22 weeks, we had started her on pyrimethamine and sulfadiazine because I was very worried that placenta is affected, the LICA is less. Let me start it off. And once the result came negative, then we shifted this patient to pyramycin. So you may have to make these sort of calculated decisions on that. So patient was put on rofamycin for BD, and frequency of ultrasound, Ritambra?
There is no change in ultrasound monitoring for toxoplasmosis per se, but then fetal monitoring in view of IUGR, less LICA, would continue, we would first like to see the baby at around 22 to 24 weeks, 23 to 24 weeks, looking at the heart, because 24 weeks the heart is very well visualized. And again, maybe 3 weekly in the entire biometry, looking at the brain, looking for the cranial calcification. That is all the signs of development of congenital toxoplasmosis. And definitely looking for intrauterine growth retardation, ecogenic bowel, and development of hydrops if there is any sign. And also there is a contrary, you may have, if the baby gets affected anytime, although the baby is not affected at the moment, you may find first subtle sign that the oligohydramnios has shifted to polyhydramnios. So monitoring is to be done 3 to 4 weekly, and earlier if there is any other sign suggestive of a fetal infection.
Excellent. So this is what you have to keep in mind, either when you're doing your own ultrasound or when you're sending to your sonologist. Please specify that look out for signs because the patient is under treatment for toxoplasmosis, because then they will know what is happening. You know, it's not a routine ultrasound which they are doing. So be careful here. So the growth was monitored over here, and at 26 weeks, the growth parameters were normal. And every 4 weeks, we did a sonography, and the Dopplers were also normal. The Leica was also at 26 weeks, just around 10 centimeters, but we kept a watch on that. So for IUGR and oligo treatment, all of you, please tell me what all do you do? There's a whole list of things which one can give. What all do you people give one by one? Dr. Kuntal first.
Sir, I just give the diagnosis as a fetal medicine consultant. I don't treat, so I will not suggest, sir.
No. You are an obstetrician, right?
No, sir. I don't do obstetric practice. I only do fetal medicine practice.
Oh, you're doing only fetal medicine. So
Yes.
As a fetal medicine consultant, do you think that anything works for IUGR?
Aspirin, yes, but if it is 13 weeks uterine PI high, in that case, it will work. Not in this case. I personally don't believe that any of this works.
So can I?
L-arginine sometimes work.
It's as Dr. Kuntal rightly said, ecosprin, the ideal time is to give at the time of placentation between 16 and 19 weeks. But the catch-up time is also up to 26 weeks. So you may start ecosprin, and if you are very sure that it is not, if it is a placental cause. In this case, maybe aspirin will not work because it is the torch infection that we are looking at. Sildenafil, I have never used. Arginine, occasionally I give it when again I know if I feel that it is a placental cause that I'm looking at. But amniocentesis group I have never been giving.
Increasing the intake of fluids and rest also sometimes helps when we find like the proper nutrition is not taken care of. So that also helps a lot in case of oligohydramnios. And regarding the current condition of the infective focus, so sometimes there may be irregular vascularity and the nutritional depletion can happen. So that's why improving the diet and nutrition also might be. That's fine.
Yeah, sorry, something went wrong and my computer shut down. Will you allow me to start the video, please?
I think the problem with our network.
But can you hear me now?
Yes,
Yes,
we
sir.
can, but we can't see your presentation, sir.
No, I know, because I'm from the phone, because my computer suddenly freezed and everything went blank.
So you restart everything, sir?
Yeah, it is just restarted. Give me 2 minutes. I will just come again. But you can discuss the IUGR part, Anju.
Yes.
That what is the importance of sildenafil? What is the importance of arginine? That's what I wanted to discuss. You can just go ahead with that. I'll just open up everything again.
Yeah,
Okay.
fine, sir, fine. So somebody was talking about aspirin, and then let's go to one by one all the topics, all the salts basically.
Aspirin
So basically,
will be
aspirin
helpful.
technically needs to be started before 16 weeks of pregnancy, but
Yeah, 13 weeks. Aspirin is normally started if the PI is high at 13 weeks of
yes, ma'am, I
pregnancy.
will check.
yeah, at 13 or 14 weeks, best is before 16 weeks if it is started. So
Yeah,
it should
yeah.
be started at least before 16 weeks. There's generally no point in starting at 20, 22 weeks.
Yes.
And this tab is again not allowing people to start their videos, so it's a problem. But anyway, go ahead and discuss the importance of, I'll just try and open again.
You
Yes.
can start your video, sir.
Yeah. So let's talk of sildenafil. Anybody has any experience of using that? Dr. Tapassu was wanted to say something.
I had used sildenafil long back, but didn't find much difference. But arginine does help. I have seen patient improve, their liquor is improved with arginine, L-arginine. So I strongly recommend giving L-arginine for patients who have got oligohydramnios and IUGR.
Is there any scientific?
That is my personal small study, so I will not say that this is a established study. It's,
Madam, the scenario is that we have to do something. We cannot. So we mostly start with arginine sachets, and mostly what I feel that viral infection, whenever the oligo is due to any viral infection, body recovers, liquor recovers, and arginine sachets. As we all know, there is no scientific proof of any of the medication for oligohydramnios. Nothing is proved essentially, but as we have to do something. So L-arginine is a good thing to be given, and we start that mostly liquor recovers.
Anybody wants to add anything in there?
Santosh, what do you do? Anybody giving this protein drips?
No, sir. Actually, whatever options we are discussing, everything is experience based. There is no evidence to it, and in spite of not having evidence, still everyone is practicing because we feel like we have done something for the patient. Things fall in place, and this is how the things are going on. But as far as the evidence goes, I don't think any of them are having a conclusive evidence of helping in such cases of oligohydramnios. On top of that, both these aspirin, arginine, they may help in oligohydramnios or IUGR, which are secondary to the vasculopathies, maybe because of the PIH and related cases. But the oligohydramnios, which is secondary to an intrauterine infection, these may not help much.
Okay, great. Now, the staff has not started my video somehow, but it is fine. When we did a scan at 26 weeks, the AC was lagging behind by 2 weeks. The 75 GCT test, which we normally do at that time, came to 184. So we put the patient on diet counseling, exercise, and self-monitoring of blood sugars. The sugars were well controlled on diet and exercise. And at 28 weeks, we gave steroids for lung maturity. Now, is that a good idea or a wrong thing? What do you think, Santosh?
Sir, she has a very high probability of landing into a full-fledged IUGR and getting exposed to a premature delivery. I know the GCT is on higher side, and giving the steroids may shoot her sugars up. But giving the steroids may be under insulin cover can help us to tackle the hyperglycemia and will help us to accelerate the lung maturity.
Okay, so that was what we did. We gave her steroids. We controlled the sugar for that time being. And would you, Sujata, if her sugar is still not under control, would you start her on metformin?
Yes, we can start.
Can you please put on my video? Listen, Vipin or whoever it is.
Yeah, we can still start them on metformin. There are quite a bit of studies which have shown that metformin is safe even in the 8th month of pregnancy. and it is also going to give a better glycemic control. And before switching on to the injectables and to prevent a little bit to be less invasive, we can offer them with the metformin treatment. However, there are some proportion of studies which say that they may be small for gestational age babies with metformin, but
Yeah.
it can still be tried.
Excellent. Sujata, it's an excellent point you made. We always prefer to start on metformin than starting on insulin. Very true. But a little caution has now come up. A little red flag has now been raised that metformin may lead to a little more growth restriction. So one has to be a little careful in starting with metformin. And if you start on metformin, you have to monitor these fetuses very closely. So just a little bit of new thing which is coming up is that be careful in starting metformin in IUGR babies or small for gestational age babies. Now, our baby did well till 30 weeks of gestation. There was no problem. The growth curves and estimated baby weight was all fine. The Likert was decreasing. It had become 8 at 30 weeks. And as gestation progressed, and remember, she is on spironolactone. At 36 also, the ASI fell to around 5.5, and we were thinking now high time to interfere, but the Dopplers were okay. And ultimately, at 37 weeks, we said now enough is enough. The AFI had dropped to only one small pocket of 2. Even though the Dopplers were fine, we did a cesarean section, and they delivered a 2.4 kg male child. On the cord blood toxo IgM was negative, IgG was positive. Now, is that expected? Yeah, because the mother had toxoplasmosis, IgG probably would be positive. There were no signs of congenital toxoplasmosis. She was advised to repeat toxotiter after 3 weeks and a very close follow-up. Now, what are the signs, Dr. Tabassum, do you look in this baby for if there is congenital toxoplasmosis?
We should alert the pediatrician beforehand, and we should ask her to see for any signs of chorioretinitis or cerebral calcifications. The baby may also have hydrocephalus, so the head circumference measurements and all are very important. Some babies may not present with any sign or symptom, but still they may have toxoplasmosis. So around 90% babies, they don't present with these kind of signs and symptoms.
Yeah, so in general, you have to be careful with these babies. You have to follow them up. The repeat cycle after 6 weeks was also normal. And this is about toxoplasmosis, a very important thing to know, because here you can have late neurological sequelae, hydrocephalus, convulsions, etc. So you have to keep a watch on these babies. There could be chance of a little hearing loss, etc. So basically, toxoplasmosis is important because it's one of the treatable infections among the torch titer, and one must know how to go about it. Now, we have very little time left, so very quickly, just to say how confusing torch could be. A primary at 12 weeks, normal NT scan, only uterine artery Doppler was raised, so we started on aspirin, otherwise the whole scan was pretty normal. Complained of leaking PV after 2 weeks, and when examined, there was no Likert. What is the cause? Is it incompetent ask? And would you ask for a torch titer in this case? Any of the panelists, please.
But I don't think I would do a torch titer in this case upfront.
Yeah, and the patient is asking for answers, so you would just label it as an incompetent os at 14 weeks?
If the cervical length and os is closed, then you can't label it as incompetent os. I would say maybe threatened abortion at 14 weeks. If the os is open, yes, incompetence can be labeled as a cause.
I totally agree with you that in general, you may be wary of torch titer, but when a patient wants answers, you probably would get even the torch titer done in addition to the things you will do for APLA syndrome, because this is the first abortion, but it is happening at 14 weeks. So it is not always easy to label it as a chromosomal defect. Of course, we will send things for chromosomal defect also. We send the products of conception and found out that it was a normal pregnancy. In the torch titer over here, the herpes this herpes simplex virus 1 and 2 came positive. So what do you make out of it? Do you think herpes is responsible?
No.
Yeah, so it is very difficult to say that whether it's responsible. And then you always get a report like this with, 10 things put, the IgG always put high, so the patient feels कि देखो इतना सब गड़बड़ हो गया है. But you have to be very careful in interpreting the result that if the torch titer is negative. And I think we'll stop here because Anju, I don't think we have the time, right? For another case, it's almost an hour. All the coordinators have gone.
Yes. Sir, what are you saying?
Sir, you can continue, sir. We still have
Yes,
time.
sir, we have time.
Sir, you can continue for another 10 minutes, 10, 15 minutes, sir.
Okay, so the last case which I have is our ventricular with megali, which is another very, very difficult case to even counsel the patient, because if you have a 24-year primary gravitas, anomaly squad at 19 weeks, Kuntal, you get a report saying lateral ventricle measures 9.9 mm. What are you going to counsel the patient?
Yeah, first of all, I will make it 10 millimeter, so it falls into ventriculomegaly. And then for ventriculomegaly, we have to first make them explain that mostly they will come and have been told that there is some fluid collection in the head, which terminology should not be used. I make them understand that this is a normal fluid which is there in the brain. The cutoff is 10. When 10 is there, two things we have to think. One is about aneuploidy, I will explain, and one is about structural. Structure, I will say that I have examined the structural. There is no other structural issue in the brain. So that part I have covered, but I have to follow up after 4 weeks for that. And we have to follow up till delivery for structural problem. And second thing, mostly if it is unilateral or bilateral, that also depends. And then for aneuploidy, we have to offer about the amniocentesis. And amniocentesis, we explain about microarray. If they want whole exome sequencing, then both, and everything is normal. For aneuploidy, if we have ruled out all the chromosome and exome, plus MRI should be done at 28 weeks. Everything is normal, 90% the fetus will be normal. So we can do this many things and follow up the patient. And if it is not progressive, then
so would you do with the amniocentesis, would you do a torch PCR also?
Torch PCR, yes. Microarray, torch PCR, and SOS whole exome sequencing, depending upon the other features.
So there is a role of torch infections here. It can cause this. Over here, the previous down screen was low risk, and we asked for a torch titer. And of course, this is what all Kunta has already said. And the torch titer, CMV, IgG, and IgM came positive, and the CMV avidity test was no positive. So is the fetus affected by CMV? And what is the rate of fetal transmission in this? Who would like to answer this? Because she's a fetal medicine expert, so obviously it should go to her. But anybody else, Sujata or Vitamra or Tabassum, anybody who is there as my panelist?
This fetus is
or shall we ask Dr.
affected
Kuntal
by-
to?
Yeah.
So for as such IgM and IgG positive, first we have to repeat the titer after 2 weeks. And if both titer are increasing, then only I will consider it Ig avidity test and plus increasing titer. Then only I will feel that this is the infection. And if we are suspecting infection, then after the probable time of infection, we will do the amniocentesis. And then only we will think that fetus is infected. And then only we treat or follow up like that. So for IgM,
But
IgG,
CMV will,
yes, sir.
yeah. So basically for CMV we don't have much to offer, right?
Yes, there are some studies are
What
not
is the treatment which you can offer to this patient?
No, but how can we repeat the test? Because this amnio report, right?
No, sir. I'm saying for blood test, torch titers should be repeated after 2 weeks. Amniocentesis, if positive, is positive.
Yes.
No, but this was a torch titer in blood, and PCR also came to be positive. So the baby is affected, and as sir said, we have
PCR
nothing
is
much
not
to
positive,
offer.
madam. This is torch titer, IgM.
No. We haven't done amniocentesis as yet.
Okay. Okay.
As yet, we have not done amniocentesis.
PCR positive means positive. Titers, I
Yeah.
am saying I would like to see increasing titer only. Then only I will put the needle. Before putting the needle, I would be confirming that it is increasing titer.
Avidity,
This
you
is
would
not
you would not
treatable.
look at the avidity and prognosticate, or you would still wait for the another rising titer after 4 weeks.
No, 2 weeks will also be fine. When one torch titer is positive, avidity, if IgG positive, avidity has been sent. For avidity, I would also like to say that avidity, if we have, say, 26 weeks patient comes to me, says IgG positive, avidity is low, then it's recent infection. If avidity is high, then also it is in the pregnancy itself disease has been infected. So
Yes.
that's the case when avidity is not judgmental. So if increasing titer are there and sonography is also suggesting there is high suspicion of infection, then only we do amniocentesis for solve infection. If ventricular megali is there, we are putting the needle because we are suspecting aneuploidy as well as we are sending torch PCR along with it.
Exactly.
Major
Correct.
thing is
Correct.
aneuploidy.
Agreed.
Yeah, sorry, I missed a little bit because my connection wasn't good.
And for CME, gemcitabine
I
came into picture.
Fetal medicine expert giving us exactly the view what we should be doing. At 32 weeks, the lateral ventricle started expanding more, and we told the patient that you require amniocentesis. With that, we also gave her a little bit of information that the rate of congenital transmission is not very high. Congenital CMV is reported only in 1% of live births in USA. 7% of those infected manifest symptomatic disease. Means very low percentage gets affected, and 93% of the fetuses do well. And that is the intrauterine transmission from primary maternal infection is 30 to 40%, and only 18% of these will develop significant disease. And of course, if there's a recurrent CMV infection in the mother, then the fetus is never ever affected. So doing all this, knowing that only 2% of women are at risk of fetal disease is low, because this woman had already reached now 32 weeks when the ventricle started enlarging, she says, no, I don't want any amniocentesis, and she refused amniocentesis, and this case is of around 7 years back. So basically, we just let her do, and of course, please remember, a therapeutic abortion is not recommended even if primary maternal infection is documented. So of course, here it was too late. We had that ventricle bloating up only after around 32 weeks. So this is what a routine maternal CMV is, of course, not indicated. You have to look out for all these signs. And anybody else wants to add anything to this particular case, please, most welcome, especially Kuntal if she is going to give her inputs on this.
Sir, now some
Or
studies.
Sambara or Tabassum, because this is the last case which we are discussing.
Yes, sir.
Yeah, Santosh?
Yes, sir.
Anybody, please?
So most often we come across such patients with the IUGR as a presentation with oligohydramnios, or may not be there, but IUGR is generally the presentation. And yes, patient asks for an answer and torch, we do. And as you rightly said, since there is nothing much to offer to the patient, we follow the patients till the delivery, and most ventricular megalies do not end up in hydrocephalus. So I think I'm sure your patient must have also done good.
Yeah,
And if
patient
there
is
is a
well.
if there is rapid progressive hydrocephalus, then maybe shunting would help after delivery. So the pediatric surgeon would decide that that baby would need shunting or not.
Yeah, so it's only after delivery when you can do this, and of course you could give steroids and all. and patient delivered normally and showed mild hydrocephalus and no interference was required in this particular case. So thank you all very much for this lovely discussion which we had on torch infections. And thank you for all the inputs. And I thank Anju here who brought us all together for this fantastic discussion. Anju, you're doing a great job and all the best to you.
The most important thing which all of you have focused is, in these cases, we know what the results are, but the counseling is very, very important because
Exactly.
the counseling to the patients, sir,
Yes.
that is the most important part.
So that is the importance of knowing about these infections. Just getting a report and then panicking and telling the patient, "Arey, ye to theek nahi hai," it's not right. You have to be very careful in what. If you tell the patient, "Arey, ye to theek nahi hai," then the patient says, "Abortion karo." So you have to be very careful on how you counsel. Your body language changes when you get a report. So you must be aware of what you are doing and how to tackle with these cases. And we have people like Kuntal here, or everybody as fetal medicine experts. Simple phone call and asking them, "This is the report. What shall I do next?" would also be a great help because we can't know everything. We don't know everything about all the diseases. But it's been a great discussion. I thoroughly enjoyed this thing, and I'm sorry for the interruption because of the unstable Wi-Fi connection here.
That is very important part of the webinars, the
I know.
connection loss.
So I have to shift my room. But anyway, thank you.
Thank you, sir.
Very much. It was great to talk to all of you and get inputs. And anybody has any questions? There were some hands being raised, but I don't know who was. There are no questions here. But any other inputs or any other questions?
Thank you once again to everyone. Thank you so much, ma'am, for including me part of this webinar. It was pleasure meeting you, Dr. Anju, when you were here in Chandigarh. Once again, it is good to see you. Thank you so much. Thank you, Dr. Uday.
Yeah, and pleasure meeting you, Ranju ma'am, in Raipur as well. So thank you so much for coming to Raipur, and seeing you again is a pleasure. Thank you so much. And thank you, Uday sir, for a wonderful panel you moderated today.
Thank you, Dr. Uday.
It has been a very, very practical panel. Very, very practical, the type of cases we get in our day-to-day practice, and how they test our so many years of experience. That is the most important part of this discussion, which Dr. Uday and you all experts tackled it so well. So before going to the thank you from my beautiful team, I would just request every one of you to please, just a soft request to please support me. I'm going for the post of Vice President from West Zone, and I request all of you to please support me in this endeavor of my life. And over to you, Shruti. Are you there? Or Cindy?
Definitely. Yeah, Shruti is there. She raised.
All the best, ma'am.
Yeah, and I think Dr. Shruti is not there. So thank you everyone for this wonderful panel discussion, which was very practical oriented. As we all know, intrauterine infections, there can be various causes of intrauterine infection, and almost like 2 to 3% of congenital anomalies, they are attributed to some or other perinatal infections. So rightly identifying them and counseling the patient at the right time is very important. And as Dr. Uday Thanawala sir and Anju, we are all discussing right now, that actually we also practically see so many times that, patients, they get the torch report, and we have seen very totally mismanaged torch report. They are managing the patients on the basis of torch reports. So exactly understand what is the implications of the IgG, IgM, the increasing titers of IgG, and what is the importance of avidity, and then properly treating the patient as per the, after properly interpreting and understanding the torch report. That is very important, rather than just writing a torch, to advising a patient to get a torch. So it was a very wonderful and fruitful panel discussion. Thanks to our very great moderator, Dr. Uday Thanawala sir. Thank you very much for the wonderful moderation. And thanks to all the panelists for their wonderful and great inputs.
I will not call them panelists. They were all experts in their own field.
All are experts, yeah. Just as Anju ma'am always says, it is the moderator who brings them all magically together so that they can also share their extremely, experienced and, well read inputs so that we are all benefited from all of the inputs. So thank you all. Thank you very much for this wonderful